Hello, welcome to the Burn and Environmental Management section for Apollo MedFlight's orientation. My name is Damon Crabtree. I'm the lead field training officer and a flight paramedic here at Apollo. If you need to contact me, please reach out at any time. My email is dcrabtree@apollomedflight.com, and you can reach me by phone at 806-206-8015. This section should prove to be fairly quick and easy. Everybody has some experience with burns, heat illnesses, and cold illnesses is something that's hit on really heavy in school, but might not always be a common patient that we run into, especially depending on your location. This PowerPoint, we're going to discuss management of burns, obviously, review the heat-related and cold-related illnesses, discuss briefly rhabdomyolysis and the labs associated with that, and then we'll do some practice questions over burns and the rules of mines. Okay, so there's a couple types of heat-related illnesses. Your main burn emergency is going to start with least intrusive for the body. That's going to be heat cramps. Probably everybody's ran into heat cramps in their life, on themselves, outside, working hard, not drinking enough water, and all of a sudden you get a spasm feel in your leg, and it just doesn't go away easily like a normal cramp would. Heat cramps are very common, easy to deal with. It's usually just due to a little bit of dehydration and isn't truly an emergency. The emergency part about heat cramps is the fact that it might precede heat exhaustion or even heat stroke. So heat exhaustion is usually somebody that's been outside for several hours or doesn't respond to the environment very well, like a infant or elderly who easily loses water and doesn't have built up reserves to really deal with that kind of environment for a long amount of time. The lab values that you're going to want to get is going to be your CBC and then your chemistry for sure, because we're going to look for an elevated hematocrit, elevated BUN, elevated serum protein, and concentrated urine levels. So all that's happening right there is with an elevated hematocrit is that you're losing your total body water. So you're losing water and fluid within your body, and so it's really concentrating the hematocrit. The BUN, just due to a little bit less of renal perfusion and the ability to clear stuff out of the body, you're going to start to see your renal labs begin to elevate. The elevated serum protein, same thing as the hematocrit. It's just getting more and more concentrated along with those urine levels. Other things you might find is hyponatremia and hypokalemia. Hyponatremia is just the loss of sodium out of the body as you sweat. And then hypokalemia, you're also going to lose that as well. Hypokalemia being one of the most serious types of abnormal lab values. And then finally, heat stroke is the clear life-threatening medical emergency. Is going to have everything from the heat exhaustion, except for they're going to develop altered mental status and coma. Here's just a picture of the best things you can do for the patient is, if you had access to a fan, you'd want to get that running passively over them, get their feet elevated so we make sure we get all the blood, shunting back to the core and out to the body again. And then having the patient get fluids. In our transport environment, we don't really have the patient drink, so we'd want to just do IV hydration as necessary. So our hallmark sign of heat stroke is going to be the CPK of greater than 20,000. So extremely high CPK. That's not extremely, it's not a common thing to see with any other type of disease process. So core temperature greater than 42 degrees, they're going to be trying to blow off a lot of acidosis that's building up in their body. So they're going to start hyperventilating, extremely fast, up to 60 breaths per minute, just trying to, regulate their body. It's soon after that, it's going to develop, dysregulation, where they're not able to control it. Their body's way too hot, and your brain doesn't function the way it should. Like I said, you're going to develop some central nervous system dysfunction as well. So that could be altered mental status, seizures, or even just frank coma. The difference between heat stroke and heat exhaustion is you stop sweating with heat stroke. So the skin will be hot, obviously, and very flushed. And in the beginning stages, you might have sweating, but soon you're going to run out of that response, and you're just going to be hot and dry. So complications of heat stroke, due to the body's response of trying to get, your blood cooled off, you could develop pulmonary edema. In that case, it'd be, too much loading back into the heart, and your heart not being able to pump effectively, either because the fluid's coming back, too fast and it's flowing, or your heart begins to stop functioning like it should due to the temperature and the complicating acidosis. You're obviously going to have tachycardia, BUN. Eventually, you're going to lose your urine output as you lose fluid, and that will develop into liver or renal failure. And then you're going to get a hit on your liver. I mean, your kidneys are the very end organs, and what backs up after that is directly to the liver. Especially with a bunch of blood, shunting. With liver damage, you could develop jaundice, and then GI bleeding is common, especially with dry stomach and bowel, because you're not intaking fluid and you lost it. It's just really easy to abrade any vein that's hanging out in the stomach and cause the GI bleeding, especially with backed up liver perfusion. So what we're going to do with heat strokes is we're going to begin with the passive cooling. So, body temperature is usually going to be 104, 105, 106. So we're going to start, have a fan on them. If you have the ability to splash water or spray water, that's going to help cool them down. Cold compresses over the top of their arteries, so radial, axillary, femoral, even carotid if you need to, and then aggressively monitor temperature, preferably with invasive monitoring, but that's not always in availability, so we just want to do temperatures, Q15 at the minimum. Once your body gets down to 102, we're going to start backing off some of those cooling measures, because we're going to run into them dropping too low and then begin shivering. And which is going to complicate it further, because it's just going to rise the body temperature back up. These sections are going to need fluid. They're going to be really dry, and they might need the assistance with vasopressors in order to get your map up to 60, 65, your systolic up to 90. If they have altered mental status, seizures, any type of coma, they're probably just going to require innovation, especially before we transport them, because trying to innovate in the aircraft is less than ideal. It's always a good idea to put a G-tube 10, either a nasal gastric tube or an oral gastric tube, just to get any air out of that abdomen. You have to be cautious, just because if they're already at risk for GI bleeding, misplaced gastric tube could start that GI bleeding. They might require H2 blockers or antacids to try to prevent any GI bleeding. These patients all need a Foley catheter, because for adults, we want to have a strict at least 30 mils an hour while they're in the heat stroke phase, or pediatrics 1 to 2 mils per kilogram per hour. And then we're just going to kind of titrate fluids to achieve those goals. Hypokalemia is, the worst thing for lab values that can probably happen, because it takes so long to replace. So we'd want to monitor what their potassium is if it's coming out of the hospital, and start replacing fluids prior to correcting the acidosis, because as we correct the acidosis, it's going to drive our potassium down even further. So if they have a lactic acidosis and their pH is 7.1 and their potassium is already 2.8, well, if we start giving them fluids and making them pee and get rid of some of that acidosis, it's going to drop their potassium even more. We'll control seizures just like we do any other seizures, so we're going to use benzodiazepines in order to get that going. If you need to help your kidney perfusion with hopefully just giving a couple liters of fluid is going to promote urine output. You could move on to forced diuresis, where mannitol, Lasix, or sodium bicarb. We don't carry mannitol right now, so Lasix is kind of the main drug that we'd want to give, and then the sodium bicarb could help also push fluid out to the kidneys a little bit further. We don't have Thorazine, so if your patient begins shivering, you'd want to just either sedate them appropriately, or ketamine and etomidate are decent alternatives to try to prevent any shivering. So rhabdomyolysis. This is something that can happen after heat stroke, very common in elderly patients that have fractured a hip and laid on the floor for a couple hours. So it's characterized by muscle necrosis. So somebody has a trauma, they have heat stroke where they're not perfusing the muscle, or they lay on the ground in this awkward position for a long time. It degrades the muscle, and those components of the muscle cell get pushed in circulation, so CPK, myoglobin, and it's going to cause a lot of dysfunction. So, kind of like I already said, ways that you can develop rhabdo is from heat-related illnesses, crush injury and trauma, especially compartment syndrome, because it's going to rapidly kill off any muscle inside that compartment. Patients with alcoholism that have trauma, seizures, coma, and just kind of lay in an awkward spot, and then snake bites, drug use, etc. So your main symptoms is going to be extreme malaise, fever, tachycardia, nausea, vomiting. Sometimes you could have altered mental status due to encephalopathy. So our labs for rhabdo, you're going to have an elevated hematocrit because you don't have a lot of fluid flowing around. You're dehydrated, so your hematocrit's going to rise. Real big part of rhabdo in the diagnosis is this tea-colored urine. So your urine's going to be very brown in color, extremely concentrated. Your CPK is going to be greater than 20,000. Eventually, you could develop DIC along with the renal failure and hyperkalemia. Along with that renal failure, increased BUN and creatinine. So the complications of rhabdo could be extremely lethal, obviously, because they're going to develop a bunch of byproducts in their circulation that are going to get shot into your vital organs and cause dysregulation. So the hypovolemia is a huge part, could cause hypotension. You're going to have some dysrhythmias and possibly cardiac arrest due to the hyperkalemia and the other myoglobin that's flowing around in your body. They could already have compartment syndrome, or they could develop compartment syndrome. They could develop, DIC, and then obviously almost all of them are going to have some sort of acute renal failure on board. So in order to do best for the kidneys for these patients, we're going to aggressively fluid load them. We're shooting for a urine output of 30 to 50 mils an hour in adult, and then pediatric 1 to 2. This is definitely a good place to consider this forced diuresis. So your Lasix or mannitol might come into place. And then maybe consider some alkalinization with sodium bicarbonate. Just make sure that you give sodium bicarb either as like a replacement fluid, so a couple amps of bicarb into a bag of D5W or sterile water, or you give it extremely slow IV push. So again, just to recap, rhabdo, your hallmark sign is going to be a CPK of greater than 20,000. You're going to have elevated renal perfusion, dark tea-colored urine, going to decrease your urine output, and you're going to develop altered level of consciousness. So your cold illnesses, different types of warming. So you can have passive, active external warming or active internal warming. Easy enough. Our passive external warming is where we want to keep them into a warm environment and cover them in blankets, which becomes very hard in the transport situation. So we want to go above and beyond to make sure we have enough blankets, that the blankets aren't wet, and that we have the heater on in our aircraft. Our active external warming is going to need to be used in conjunction with that passive external. And that's where we're going to, use hot packs around the peripheral arteries, where we can try to get as much blood flowing past those hot packs. If you have access to thermal blankets, what we have is a cocoon, which is a thermal blanket that kind of looks like foil. That kind of helps keep in their heat. So pretty much every patient should get wrapped in those, especially when it starts getting colder out. And then active internal warming is something we're not going to really have too much of the ability to do. We do have an IV fluid warmer in the helicopter, and that's about the extent that we're going to be able to do any active internal warming. So big thing with your hypothermic patients is to monitor for after drop. So that's where, they're shut down, clamped in the peripheral. So they're not really getting the blood back from the legs or the extremities, and we start aggressively warming up their core, and all of a sudden their body's like, oh, hey, I'm not as cold as I was. I'm going to dilate and bring blood back from the periphery, and then all of a sudden that blood that's out there, at 20-something degrees Celsius comes back to the core and drops them, very quick. It's like giving them a fluid bolus of, chilled saline coming back from the body. This rapid drop could be a precipitant of ventricular fibrillation, which in the hypothermic patient is really difficult to manage. The best thing to prevent this is to wrap up their core or their extremities tightly with blankets, so we don't want to cover them, make sure they don't just have their leg hanging out in our cold environment, and try to get them to warm up the extremities, on a controlled basis before we get their temp up really high, and that after drop, becomes a potential for happening. So different type of hypothermic injuries, frostbite is what's going to be, usually isolated to, the distal extremities. So your fingers, toes, could move up to the hands or even further on up. That's where your tissue is actually frozen. So we're just going to try to, maintain where they're at until we get to some sort of surgical intervention that can, monitor. Because if we start rewarming, there's a potential that in our environment that they could refreeze, and that's going to complicate the matter even further. There's a couple different degrees, just like burns with frostbite. So first degree is inflammation and edema without actually killing off any of the skin. Second degree is you're going to start developing blisters and have abnormal sensation. Second degree deep, it's going to have the blisters along with the second degree superficial potentially, but it's going to be more of a held kind of cyanotic extremity. They're going to have a lot of trouble with sensation at that point. Your third degree full sickness is necrosis to this underlying structures of the superficial skin, so all the dermis. Best management is to just keep whatever limb submerged in just, ambient water, cool water, so it doesn't warm up too quickly. Your different types of hypothermia. So mild is going to be diagnosed as 89 to 95 degrees Fahrenheit or 32 to 35 Celsius. And the symptoms are just going to be your normal body's response to a cold environment. So tachypnea, they're going to try to either they're uncomfortable in their environment or the body's telling them to breathe faster because they're not getting oxygen out to the tissue due to vasoconstriction, which is the second symptom. They could have tachycardia and hypertension as they try to pump blood all around their body, ataxia, so they can have a dysregulated form of breathing, slurred speech, difficulty with fine motor function. They can begin to have altered mental status, starting with lethargy or what would look like apathy, where they just don't really seem like they're concerned with their situation as much, and then obviously shivering. Moderate hypothermia is 82.4 degrees Fahrenheit to 89.6 or 28 to 32 Celsius. This is where your shivering is going to stop. Patients going to develop dilated pupils. They're going to have delirium with altered mental status, extremely slowed reflexes. The body's going to develop bradycardia because it's going to begin slowing down, and it's not going to realize that it's in a critical state at that point. And then cold diuresis. And then severe hypothermia is anything less than 28 degrees Celsius or 82.4 degrees Fahrenheit. And this is where your patient's going to be unresponsive in a coma. They're going to appear dead. That's going to be just their body completely slowing down. They're not going to react to their environment. The pupils could be fixed. They're going to be hypotensive, extremely cold. This could precipitate pulmonary edema and apnea. They become acidotic because they're just not going to have circulation around their body, especially with apnea. It's going to complicate even further. They could just be in ventricular fibrillation, or they could actually just be asystolic. Not going to really have any reflexes. And in the ECG, they could have an Osborne wave or a J wave, which is kind of a blip on top of the J point. Also, another sign of hypothermia on the EKG is a prolonged ST segment. The only other thing that causes that is hypocalcemia, so it's pretty easy to decide where that prolonged ST segment is coming from. This is what your Osborne wave looks like. So down here on top of the J point, you're getting this little wave, and that's just pretty much the only thing that causes it is hypothermia. So if you see that, you probably should have already identified that the patient's hypothermic given a temperature or just touching their bodies. It's a bad sign. So it means that they're having trouble with their heart, and ventricular fibrillation or asystole could be the next rhythm. What we're going to do with hypothermia is we're going to try to manage any further heat loss and start passively rewarming them. So that's going to be get cold, wet clothing and then immediately cover them up. And every time that we try to remove clothing, we're going to want to do it quickly without jolting their body, because we don't want to leave them just laying on our bed completely uncovered and wet. So we want to remove wet clothing and then dry that off. And then every 15, 30 minutes, we want to just make sure that blankets haven't been soaked through, because we want to pull them off, dry them again, and then replace with warm blankets. Biggest thing we can do is remove them from the cold environment, which we can't really do very well. In the winter, our aircrafts are going to be cold, especially on the ground. They're not going to heat up until a couple, 5-10 minutes of flight. We want to do smooth transport, so we don't want to jostle them around because it could send a ventricular fibrillation. And obviously, if it's a drowning or just a hypothermic patient, if they don't have signs that they've been dead for hours upon hours or days, we're going to work them until they're warm and dead. If the patient's in ventricular fibrillation, we're going to shock them one time. If it doesn't convert, then we're going to just work them and do really good CPR, start warming them, intubate them, but defibrillation is not really going to be useful until they get warm. Also, we're not going to give any IV drugs if they're extremely cold, because they're not going to burn off, epinephrine. If we give them a couple amps, it's just going to be floating around their body, and then if we ever do get them warm enough to get them back, they're going to go back into defib or deep attack because of the epi load. So if they're below 30 degrees Celsius, we're not going to do any drugs. And once they're above 30 degrees, we're going to give epi sparingly. So we're not going to give it every 3 to 5 minutes. Maybe we're going to give it every 10, 15, even 20 minutes, depending on the situation. All right, so burns. This is a patient that decided to pour gasoline or some other sort of fuel on herself and light herself on fire. She was originally talking upon arrival, so if we showed up and she's still talking, obviously we're going to want to aggressively control the airway because she clearly has an airway burn. Not only that, she has 50% burns in the body. She's just going to need really heavy pain management, so she's going to have to be intubated so we can control her pain anyway. So your different zones for burns, you're going to start with first degree. First degree is just like a sunburn. It's the very superficial part of the skin. It's clearly red. It's extremely painful. Your next is the second degree. So you're going to have partial thickness and then full thickness burns. Both of those are going to be second degree. That's where the superficial layer is clearly burned. And then it's getting into the dermal layers from the superficial down to the deep dermis. You're going to have blisters, and it's going to be extremely painful. Third degree is going to burn all the way through those dermal layers and then down into the sub-Q tissue beneath that. And then below that, fourth degree is going to be it's going to be charred and leathery skin, so it's going to burn even below that. Stand by 1 second. All right, so the rule nines are going to just be our way of estimating the amount of burn surface that's actually affected. So really it's going to total 100% at the end. What we're going to count is everything above first degree. So any second, third degree, fourth degree burns. Your head's 9%, anterior chest 18, back's 18. Each upper extremity is going to be 9%. Each leg is going to be 18% total, and then your perineum is going to be 1%. If it's a small area or a partial area of each side, if you just take the patient's palm and kind of estimate how big that is, that's going to roughly equal 1%. For pediatrics, because they have a larger head in proportion, they're going to have a little bit different rule of nines. So their head, instead of being 9, like an adult, it's going to be 18% of their body. Their chest and back are also going to be 18. Each arm's going to be 9. The perineum's going to be 1, and then each leg is just going to be 13.5%. Whenever it's a leg without the premium or with the premium involved, it's going to be 14%. And then same thing, the pump's going to equal about 1%. Your electrical injuries, so you have two different types of current. So you have alternating current and direct current, so AC and DC. The alternating current's the worst one. That's what's going to make them hug. If they touch a hot pipe or something, it's going to keep them attached to it. So it's going to be a lot higher of a dose and cause more likely to cause ventricular fibrillation, severe injuries. This is where they're going to have a blowout because it's going to cause them to hold on to whatever they touched, and that's going to have to blow out somewhere. Direct current is just kind of like a zap. So they just get like one big pop, and then they usually just have the injury to deal with, and it doesn't always cause ventricular fibrillation like AC will. So this is just a picture of blowout out of the patient's left foot. So burns, we're going to want to consider early intubation. So any sign that there was an airway burn, so if they have facial burns, if they have cinched facial hair, if they have black sputum, or obviously if they have stridor and airway compromise. I said earlier, severe burns are going to be in a lot of pain. So in order to control that pain, we're going to have to give them a lot of narcotics or maybe ketamine. And they're probably going to necessitate intubation, even if it wasn't airway burning. For your circumferential burns, so if you have a circumferential burn to the extremity, that's going to develop compartment syndrome as edema develops due to the burn. So the treatment for that's going to be aspirotomy. The worst type of circumferential burn is going to be a circumferential burn to the chest because it's going to inhibit our ventilations, and eventually they'll develop so much edema and their skin's going to get so tight that we're not even going to be able to get a breath in. And obviously if that happens, the patient's going to quickly die. So they were going to require an aspirotomy, which is a deep, calculated, almost surgical cut of the skin along the lines of the skin in order to break away those sections to allow for chest expansion. Aspirotomies can be done on any part of the body that has full thickness burns, and it's just to relieve the compartment syndrome. Your chemical burns, they're an agent that is activated by either water, air, some other chemical, and causes destruction of the tissue. So there could be dry ones like lime that if for some reason you show up and they still have it on, and we want to make sure they get decontaminated. Luckily for our flight environment, most of these patients should be clean prior to us putting them in our aircraft. The dry chemicals we want to brush off before we flush. And then flushing is the way that we're going to try to relieve at least the symptoms from developing further. And then we're just going to treat it kind of like normal burns after that. We're going to keep it covered. All burns, we want to make sure that they stay warm. We are going to discuss how to get fluid in a second. And wherever the actual burn injury is, we're going to want to keep that covered with sterile dressing or a burn sheet. All right, so you get a 72-kilogram patient presenting with second and third degree burns to their entire face, anterior torso and complete left arm. How much fluid we want to give in the first hour due to Parkland. So remember, Parkland is 4 times body surface area burn times kilograms. So what we're going to have to do here is calculate what their body surface area burned is. So if we have the entire face, it's not saying entire head, so entire face would just be half of it. would be 4.5. Anterior torso would be 18. And then complete left arm would be 9. So 27 plus 4.5 equals 31.5. I just get out my calculator. 31.5 times 4 times 72 equals 9,072. And then we're going to divide that by 2 to get our first 8 hours. And it's going to be 45.36. So our best answer is going to be A. And that's what the answer was. Our next question. So we have a burn patient who has 65% burns and they're 90 kilograms. So Parkland, we're going to do that again. And we're also going to calculate it out to the first 8 hours. So 90 times 65 times 4 equals 23,400 divided by 2 equals 11,700. All right, so there's also a different formula, and that would be the modified Brooke formula, which is 2 mils instead of 4 mils. There's some more change in like the burn centers from going, always giving the Parkland burn formula given a huge amount to giving this less formula, and even some burn centers that are just titrating due to urine output nowadays. So we're going to do the same thing if we need to do a modified Brooke, except for we're just going to times by 2 instead of by 4. And then there's the consensus, which kind of takes the two together and kind of gives you the option of giving 2 to 4 mils kind of based off of urine output. So consensus formula, that's going to be 2 to 4 mils per kg times body surface area. So you're going to get a range for all those answers. So your 70 kilogram patient, so 70 times 5 equals 3,500. 3,500 times 2 equals 7,000. So that's going to be our 2 times body surface area times kilograms. So 7,000 divided by 2 equals 3,500. So it's going to be this 3,500 to 7,000 because you're just going to do both those formulas. So what's the most commonly used organ system within the body? It's always going to be the integumentary system. Sorry, it's going to be your skin. It's what's exposed to the environment, so it's going to get the most insult from that. All right, so you have a 25-year-old female or 25-year-old male burns to his entire face, left forearm, and right hand. So we just need to calculate body surface area. So entire face is going to be 4.5. Left forearm, so that's only going to be half of the arm. It's going to be 4.5 as well. And then right hand is just going to be around 1. So entire face 4.5, left forearm 4.5, 9. Right hand would be 1 more, so 10. Going to be a little bit more than that, so it's probably going to be this 12. Oh, it's 19%. So your entire face being 4.5. Oh, I didn't calculate that there was a entire portion of his right leg. So you have 10 plus 9 equals 19. My bad. Your normal potassium is going to be 3.5 to 4.5 or 3.5 to 5, depending on the monitor that you're using. So where their normal lab values would be, and creatinine is going to be 6 to 25-ish for 23. Creatinine is 0.6 to 1.4. Mag can be 1.5 to 2.5. Sodium is 135 to 145. And serum is 285 to 295. So what are the common problems associated with electrical injuries? It's going to be this myoglobinemia or myoglobinuria, because we're going to damage that muscle, and it's going to get rid of that myoglobin, and you're going to have to excrete it somehow. So we're going to want to manage urine output, and for adults for electrical we're going to do 100 mils an hour. In pediatrics we're going to double the 2 to 4 mils per hour compared to most other injuries. So when managing a patient with electrical injury, we should maintain urine output of what? Well, we just said it. It's 100 mils an hour. What drugs could be used for forced diuresis? And that's just going to be, your diuretics, so mannitol, Lasix, or sodium bicarbonate. You get a patient, 90 kilograms, 65% burns, and they want you to do the Parkland. So just get out your calculator. Remember, you just use the formula like everybody's been taught. So 90 times 65 times 4 divided by 2 equals 11,700, which seems a lot like the one that we already did. You'd expect the patient's heart rate to do what for each degree above 37? I believe it's increased 20. And then your respiratory rate's going to increase by 10. Basic management for a hypothermic patient. So we're going to want to do passive external warming first and foremost, and then move on to active external and then active internal. Hallmark indicator of rhabdomyolysis is going to be this elevated creatinine kinase. So you have a patient that has a history of seizures while on a fishing trip in July. Her husband drove her to the closest ER, lab reveals CK 28,000, elevated BUN and elevated creatinine, and her urine appears dark with only 20 mils over 2 hours. She's unresponsive with kind of marginal hypotension, tachycardia, tachypnea. So this is going to be a rhabdomyolysis, and that's it. If you guys have any questions, please shoot me a text, email me. Other than that, thank you for watching Burn Environmental Management. Have a good day.